be here. And thank you team Tnisg Midterm who gave me an opportunity to be here in this discussion. And to talk about pancreatic fistula, it's such a complex area and it's given a multidisciplinary approach. So what do you mean by fistulizing communication? If there is any abnormal passage being made between one epithelium to another, either through a surgical intervention or the abnormally created tract, it's nothing but a fistula. In pancreatic fistula, regarding the abnormal communication being happened between the pancreatic ductal epithelium as well as with the another epithelium surface. So what is going to happen once the pancreatic fistula gets established? There will be a leaking of secretion which will be predisposing to multiple complications enough to prevent the immediate further problems. And there are various classifications for that based upon your anatomic location, the underlying disease process, not the disease process the patient is going to land up, or whether there is any immediate predisposing factor. For example, your gallstones or something else. What is predisposing factor we need to look into? And what is the basic classification anatomically we are supposed to look? One thing will be your internal fistula or external fistula. And what do you mean by this internal fistula? In which they were communicating with within your pleural cavity or within your pectoral cavity, which will be predisposing to pancreatic ascites as well as your large pleural effusion, and it could be predisposing to bronchial fistula as well as a pleural fistula, mediastinal as well as pericardial, multiple other presentation. And regarding your external fistula, which is mainly predisposing by a surgical intervention. For example, if you're planning to do any percutaneous drainage or if you're planning to do a PCD for psoriasis cavity, in that kind of cases we are going to develop an external fistula. Or if the patient is having any pancreatic and cutaneous fistula, if the patient is having any other intervention is going to get happen. The predisposing main etiological factors mainly by iatrogenic post-ERCP might be operative trauma, and apart from that, the injury will be predominantly in the trach, as well as if you are going to involve the tail of pancreas, splenic surgeries, renal surgeries, or retinal intervention, or if the patient is going to have any splenic fracture mobilization. These are all the areas which will predispose to iatrogenic injuries in your, which will make a operative trauma for your pancreatic duct. Apart from the non-iatrogenic causes based upon your common etiology will be acute as well as your chronic pancreatitis, mainly by alcohol as well as gallstone. So, to discuss about the surgical events, mainly pancreatic duodenectomy as well as a distal pancreatectomy, which will be predisposing to around 50 to 20% of the population, and these kind of patients will be landing with pancreatic fistula to develop at a rate of complications. And there is one entity what is called as disconnected pancreatic duct syndrome. You should not forget, once the pancreatic duct, if it is completely gets disrupted and the distal portion of the pancreatic gland gets disrupted, so there will be secretions will be pouring out in a discontinuous manner. At that point of time, the patient will be going for multiple complications. That's a very difficult scenario to tackle. And regarding this epidemiology, around 5 to 20% of the population, mainly because of your operative intervention of pancreatic resection. And for example, in the patient who is having evidence of acute pancreatitis, the patient may land up with pancreatic fluid collection. Around 40% of the population may develop, and in that condition, the patient may land up with pancreatic fistula. Around 5 to 10% of the population rarely may develop this kind of event. And once a patient is going to land up with evidence of wall of pancreatic necrosis, that might be predisposing to disconnected pancreatic duct syndrome, around 30 to 40% of the population. And what is the event which is predisposing? Whether the ductal disruption or the wall of pancreatic necrosis itself will be predisposing is a question we should get addressed. To talk about this pathophysiology, your pancreatic duct, if it is going to disrupted or if it is, there are multiple classifications. One is anterior pancreatic, if it is going to communicate through your pectoral cavity, or posterior pancreatic, or side fistula or end fistula. End fistula mainly because of your pancreatic ductal disruption, or high volume or low volume fistula. If the fistula's output, if it is going to be more than 200 ml per day in the period of 24 hours, or if the fistula's output, if it is going to be less than 200 ml per day, and there is one more criteria, what is called as post-operative pancreatic fistula. After day 3, if the pancreatic amylase is still going to be 3 times more than the upper limits of normal, that might be considered as a post-operative pancreatic fistula based upon your presentation. And clinical features, in which area, which site which is predominantly get involved, we need to see. And the site of leak, the size of the leak is very characteristic to determine, and the amount of glandular involvement is very characteristic pathology group for the clinical presentation. And pancreatic ascites, as you all know, low are high protein ascites, and the pancreatic amylase value will be in the higher side. Apart from the pleural effusion, the pleural amylase, there are certain case reports that to go even up to 50,000. So, and apart from that, various other presentation. But a percutaneous fistula, if the patient is having tends to have percutaneous fistula, the patient may have evidence of dehydration because of continuous fluid leak and metabolic acidosis, bicarbonate leak that will be predisposing to further complications, weight loss, along with fistulizing site, local site infections and septicemia to get progress. And this is what the basic manifestations is what have been discussed. Moderate pancreatitis is nothing but once a patient tends to have evidence of acute pancreatitis at that kind of time, if the symptoms is still persisting over a period of time, if the clinical response is not there, and if the patient pancreatic inflammation is still happening, I mean, it's still in the higher side, even after the acute event, there's nothing but a spontaneous event of pancreatitis is going to take on. Apart from diagnosis, basically by clinical assessment and your imaging techniques, follow the various imaging, your CT, MRI, US and ERCP can be added to diagnostic of various things. Apart from your basic evaluation will be your CT, MRCP, we need to see MRCP not only and ERCP not only to diagnose, also for the therapeutic purpose to place a stent in case it is needed. Apart from fistulogram, in case if you want to identify the site of internal opening of fistula which is communicating through external opening, in order to aid then we can use a fistulogram. And this is what the case, if you're going to see, if there's MRCP, the pancreatic duct which is getting disrupted and there is leak of contrast in the chain. And in this area, we can able to identify the MRCP as well as the ERCP. The ERCP we can able to identify prominent contrast leak in the chain of pancreas, and there is a prominent cut and duct disruption in this image you can able to identify. And moreover, in this kind of picture, you can able to see more tail disruption changes and septicemia to get progress. And this is what the basic manifestations is what have been discussed. Moderate pancreatitis is nothing but once a patient tends to have evidence of acute pancreatitis at that kind of time, if the symptoms is still persisting over a period of time, if the clinical response is not there, and if the patient pancreatic inflammation is still happening, I mean, it's still in the higher side, even after the acute event, there's nothing but a spontaneous event of pancreatitis is going to take on. Apart from diagnosis, basically by clinical assessment and your imaging techniques, follow the various imaging, your CT, MRI, US and ERCP can be added to diagnostic of various things. Apart from your basic evaluation will be your CT, MRCP, we need to see MRCP not only and ERCP not only to diagnose, also for the therapeutic purpose to place a stent in case it is needed. Apart from fistulogram, in case if you want to identify the site of internal opening of fistula which is communicating through external opening, in order to aid then we can use a fistulogram. And this is what the case, if you're going to see, if there's MRCP, the pancreatic duct which is getting disrupted and there is leak of contrast in the chain. And in this area, we can able to identify the MRCP as well as the ERCP. The ERCP we can able to identify prominent contrast leak in the chain of pancreas, and there is a prominent cut and duct disruption in this image you can able to identify. And moreover, in this kind of picture, you can able to see more tail disruption changes which is happening with prominent MPD in your chain of pancreas. So this is what about the pancreatic fistula in the initial presentation. Now, what is the management? Regarding management protocol, always conservative. Around 60 to 70% of the population will respond to conservative therapy, and mainly we need to target the pancreatic secretion just to come out in order to improve the nutrition process. So correct the electrolyte disturbances, significant loss of sodium, bicarb, all those things will be there. We need to correct them. And total bacterial nutrition not supposed to go for longer duration of time. That will predispose to septicemia. Enteral feeding is always preferred. And in case we are planning for enteral feed, use of NJ tube is one of the best modality to consider. Apart from definitely management, around 70 to 80% will be closed spontaneously. So we need to wait, and once a patient feels the symptoms responding, we need to wait and watch. But need by overall in the initial phase of management to be considered. Regarding the pharmacological therapy, to whom if the patients are still worsening of symptoms, there are multiple molecules being tried. Among them, octreotide, pasireotide, there are some molecules being tried. What is the role of octreotide when you are going to give at a rate of 50 to 200 mics for a duration of around 4 to 6 weeks of therapy, and if you are going to inject around 4 to 6 hours daily, that might be having evidence of inhibition of your somatostatin analog, will be having evidence of inhibition of your acceptance secretion which is coming out from the pancreas. Apart from that, but doesn't show any significant effect in your closure rate, and it reduces output as well as it improves your fistula control. And another line of therapy, your fibrin glue can be considered, in which the glue, cyanoacrylate glue can be injected. Nowadays, new innovations like a coil placement through the fistula also being tried. And endoscopic therapy is very important. Once a patient not responding to medical management, you can place transpapillary or transmural. This is what is called as transpapillary stenting, and transpapillary is major pancreatic duct. In order to relieve the pancreatic pressure, we need to place a stent. And this is the basic more time to show this video. And in this, what we are going to say, once a pancreatic sphincterotomy, if you're planning to do, that might be having evidence to reduce the size of any stone which is going to come out, or reduce the size of inflammation. All those things we're going to take on. And operative management. Operative management, once a patient fails, then we can go for operative management. Either your latent pancreatic ostomy or distant pancreatic patients having any injurious lesion which is happening in the body or pain. And disconnected duct syndrome, always we can manage supporting in the initial phase. And 3 trials, one is tail, neck and distal. So tail duct destruction, the destruction means we need to plan for distal pancreatectomy. Neck, we can place a Rowan genital loop anastomosis we can plan, and apart from that, for your cirrhosis, either you can plan for your transpapillary or transmural, and mainly we need to look for the size of the cirrhosis cavity, and if the cirrhosis size if it is going to be less than 3 pancreatic fluid collection, then we can go for transpapillary drainage, and transmural, if it is going to be more than 6, at that point we can plan for transpapillary through placing through communicating a lumen, creating a lumen between the cystic cavity as well as your gastroduodenal lumen. Apart from that, regarding other interventions, your debridement of pancreatic necrosis, operating trauma, resection, all those things you can go for, depends on the area of presentation. We need to manage conservatively, if not work, so then we need to plan the patient for surgical intervention. And to talk something about post-operative pancreatic fistula is a very common scenario. 10 to 20% of the population may land up with this. So once a patient fluid volume is changed to the higher side, and these are all the various criteria to be taken into account. And very important, post-operative pancreatic fistula, octreotide, vascularite, along with your hydrocortisone, we use in the initial phase, and we need to look into the consideration to create this, to tackle this kind of presentation. Before concluding, pancreatic fistula is a complex scenario. Identification of the fistula and proper placement of the stent, refer promptly to the proper center. That's the most important thing to tackle this. Thank you very much for being here.
Thank you, sir, for sharing your extensive knowledge with us. We invite our esteemed chairpersons and